Yeah, I've got 4 pretty quick cases here. This is one that my fellow Jamie saw last week. So this is from last month. Patient comes in, maybe a little bit of edema. They have known aortic stenosis. So this is part of their pre-op TAVR workup. And then you can see here is the day before the TAVR. They prophylactically put a pacemaker in, worried in this case the degree of calcification of the valve, whatnot, that they're going to induce an arrhythmia. And so they go ahead and put this in. And this was the follow-up radiograph that Jamie saw after the TAVR. Let me see if this is the correct one. Yeah, and this I thought was a really, look at this. I can't sync my, all right, there we go. So this was the next day, right after they put the TAVR in, and she noticed, what happened to the RV lead, and you can see it coming down and going into the IVC. And what's interesting about this one, I think a couple of things, is that we have, we get copies of the angio from the placement of the TAVR. And you can see here is here's the cine where they're placing it, and the valve's in the expected location, they inflate it. And you can see that one of these catheters here is the one where they're inducing the arrhythmia to place the TAVR. So they put the heart in VTAC or VFib, basically, so it's not moving. And so when they pulled this out, presumably it was looped around this ventricular lead, because you can see the next series that they do, it's already dislodged into the inferior vena cava. And they actually didn't recognize this at the time of the surgery or of the procedure that they had dislodged it. But you can see the proof, these were like 2 minutes apart. I think the other thing that's interesting is this patient that later that day had an abdomen and pelvis CT because they were worried about a retroperitoneal bleed, which they don't have. But I think this is one that shows the value. Hopefully, do you guys all look at the scouts on every CT that you read? Because I know it kind of, yeah, because it's kind of mixed here. I certainly learned to do that, and I try to do it in every case. And I think this is one where you can clearly see it's in the IVC all the way down, but it wasn't commented on. And I think it's probably just because they, if they had looked at the scout or thought about what this was, they would have seen it. But then next day, or after we called them, they repositioned it appropriately into the ventricle. So inadvertent dislodgement of the ventricular pacer lead during the TAVR placement.
Oh, yep. Good observations.
Now this is one that's kind of interesting, and let's see. It's just a quick one. This is a patient with an intra-aortic balloon pump, and misadventures in intra-aortic balloon pump. Here is the abnormal radiograph. And there's one case, and I forgot I was going to get a JPEG because I have it on my phone, that was sent to me of an intra-aortic balloon pump that made it all the way to the left ventricle. I don't know how this made it here, but you can see inappropriate placement across the aortic arch and into the ascending aorta, and this happens to be imaged during diastole when the balloon is inflated in this case. So this is the most proximal one that I've actually witnessed. I don't know, have you guys seen them look like this or in similar placement?
Not that far proximal.
No, I mean, maybe creeping into the distal arch at most.
Yeah, I thought this one was kind of interesting. I have no idea, how it ended up there. This was the fluoroscopy they did later, and it's back, it's around the level of the left main stem bronchus, so still lower than the aortic arch. But yeah, just a nice example for your residents and fellows of an inappropriate migration of an intra-aortic balloon pump into the aortic arch and ascending aorta.
What's with the forceps and other
the forceps? The forceps, that's a good question. I didn't even look in this case if those are, sometimes we see those if they're doing an axillary placement of the of like an impella or something. I don't know in this case, honestly.
Okay. Yeah, they were doing something.
Yeah, I mean, maybe related to the generators. I don't know in this case. All right, this one I want people's thoughts on because I have no idea what to do with this one. this is from 2018. So this is a woman who lives in Hawaii, and she was referred to us in 2019. I'll show you that CT in a moment. She had worsening dyspnea, went to see a pulmonologist, had a reduced diffusing capacity. And this is what her CT looks like. And you can see that there's, I think it's more just septal thickening, more so than reticulation. There's not really anything in the in the sense of traction. There's not a lot of fibrosis, or really any fibrosis, maybe a little bit. But it's just a weird pattern because it looks more like septal thickening. And that's 2018. Now, nothing changes, and this is a year later, and you will see that it looks maybe a little bit worse, but pretty similar appearance of septal thickening. So this got referred to us as a suspect UIP, and because this had been called reticulation, and I said, well, I don't think so. It's unclassifiable in my mind because this just looks more like septal thickening. I was wondering about some sort of deposition. Yeah. Her symptoms weren't really getting any worse. Any thoughts on what you guys would say in this case? She doesn't have heart disease.
Amyloid, or like, you know,
Yeah.
late onset Niemann-Pick or Gaucher or something.
Yeah, well, they recommended a surgical lung biopsy. She didn't want to do a biopsy at that time. And there's one other piece of information that I'll tell you in a second. There was one little behavior modification between that other one I just showed was July of 2019 or sometime last summer. And then this study, which was done less than a month ago. And her symptoms have resolved, and this is essentially normal now, except for a little bit of linear stuff at the bases. And so her change in habit was that she stopped vaping in between these. And I don't know what she's vaping, and I'm not saying that this is vaping related. And certainly I do think we're going to see subacute and chronic stuff, as we have seen in some cases, but I don't know what the heck this was or is. You know, the pulmonologist wants to say it's related to vaping, but I don't know.
Yeah, pineapple lung.
Yeah, I don't know. Seth, are you watching? No, yeah, I just like, again, I'm not going to profess that this is vaping related stuff, but it's really weird. And I don't know what else to say because that's the only thing that's changed.
Oh, no, I'm sorry, I'm here. This setup is different, so
Yeah.
it looks different. I mean, we have some cases that are predominantly septal thickening.
Yeah.
I you know, there's subpleural sparing. I mean, it could be.
This was over the course of a year, and she was never acutely ill.
Oh, you're saying, so what is the time frame between?
Well, the time frame. So there was this one's from 2018. There's another CT in 2019, looked nearly identical to this. Then, you know, we had recommended a surgical lung biopsy, and then she apparently stopped vaping back in Hawaii, and then felt better, and then we got this CT.
Yeah.
So,
I mean,
and I don't know. You know, they didn't ask the question of what she was actually inhaling.
I mean, it's definitely possible. I don't.
Yeah.
You know.
But I don't know.
Wow.
I still think we keep an eye out for weird vaping related stuff.
I think this is a therapeutic biopsy threat.
Yeah, I like that too. The lungs were scared about getting the staple line, so they improved themselves.
Got better.
Yeah. I don't know.
Good result.
And then this case was from yesterday, and just curious if anyone has seen this and what your differential diagnosis would be. But I don't really need to say much. You can just see. And the one thing I will say is that 5 months ago, reportedly, like in September or August, that she was a B cup. And now looks like this. And I'll put the scout up next to it. So she underwent a mammogram and an ultrasound, and then they were doing the CT to look for a paraneoplastic syndrome, which I think is not unreasonable. There was some question of whether she could have SVC syndrome. Certainly not going to say that, you know, that this degree of enlargement. So this is a clinical diagnosis of gigantomastia, which is rapid onset over the past 5 months. I guess I showed this to Sanjeev. He said they he saw one case of this that was reportedly lymphoma when it was finally diagnosed. But the one piece of history in her case was that she got one of these implantable subcutaneous birth control injections back in July. So 2 or 3 months before the onset of the painful enlargement of her breasts. So I don't know, has anyone ever seen anything like this? Because I certainly hadn't.
No, absolutely not. That is very odd.
But there was some discussion of, could it be a prolactinoma? Could it be some sort of paraneoplastic syndrome, lymphoma? They're going to do, they're going to do I guess a core biopsy, maybe just at random, and we'll see what happens. They're going to remove the product that she had. It's called, Nexplanon is the one that she has. But I just thought this was one of the more striking CTs I'd ever seen. I mean, she couldn't even barely even fit in the gantry and not within the field of view.
Gee, that's awful.
Yeah. So
there's some condition that diabetics get, but I can't remember what it is, nor do I remember what it even looks like. But there's some.
You can get, there's a disease called PASH, P-A-S-H, and I forget what that is called, but again, talking to my mammography colleagues, they'd never seen one this large or this rapid. So maybe it's related to the hormones.
Oh.
So. All right. Well, if anyone else has any thoughts or has seen this before, I'd love to hear thoughts from anyone. So, but that's it for me, Jeff.
All right. We were talking, I wonder, because of the symmetry of it, it probably favors a hormonal proliferation than, a lymphoma that would.
Right.
And it looks like, it doesn't look like a solid mass. I mean, it looks like there's fat in between it. It just looks like.
It does, yeah.
I've seen a CT of a lactating female. It's not it's not this exuberant, but there's a lot more dense tissue and just little patches of fat in it.
Yeah, it looks like
breast. Yeah, glandular tissue that's just gone.
Yeah.
Yeah, exactly.
You know if she's lactating, she's producing, is she leaking milk?
No, she has a couple of skin ulcers. They're red and erythematous and painful. She has she has a 2.5-year-old, but she has not recently been pregnant, nor is she pregnant right now.
All right. Cool. In case I have to go do some stuff, so far I'm okay. I'll go ahead and show my case. I just have one, and it's a cool it's flow cases. So I won't show the whole case, but I'll send you guys the whole case. So this is a repaired DORV with a LTGA, and it's had a bidirectional Glenn, which you can see coming in here to the pulmonary arteries, and then it has the Fontan component coming up here. And we've talked about this. We've seen the cases with the funny flow artifacts in the vessels, but I thought this was really cool because you get this hyperenhancement of different portions of the lung. This is a outside study that's kind of thicker cuts, but I really thought this was even like just the lobules enhance at such a disproportionate rate. I don't think I've ever seen it that striking out in the lung parenchyma. You get the pseudo PEs and stuff like that. If you guys
you can see some pretty impressive ones.
Yeah, that was pretty cool. And then there's the little tiny pulmonary arteries going there, and then you got this unhappy looking ventricle. But the cardiac MR is kind of cool too. You can see the flow in the various shunts. But yeah, I like the parenchymal thing, and let me just do a coronal real quickly.
So quickly, give me the physiology of the parenchyma, the enhancement of those vessels again. What am I seeing?
So you've got the you've got the Glenn coming, SVC coming down. Maybe Seth or Travis can answer this better than I can, but
sorry, I'm sorry.
Go ahead. Yeah, go ahead.
No, they preferentially direct flow of these shunts because there's a bypass of the right heart and there's a superior venous anastomosis to the PA and an IVC to the PA, but they direct them preferentially into one versus the other. So like Glenn flow will be preferentially into the left PA and Fontan flow will be preferentially into the right. And that's why all the time, these people, when they have a PE study and they inject through a central vein, the flow goes to one side and not the other, and they say, oh, there's PEs all, you know, on one side versus the other. And honestly, if you image this patient, so this is basically contrast being injected at whatever rate, 5 cc's a second, basically directly into the lung. And if you acquired the same image at, you know, 120 seconds, it would look completely normal. It's just due to preferential flow of the shunts and the rate that it's being injected from the central vein directly into the pulmonary system.
Right. You can see this undiluted contrast coming in from the arm, going down the Glenn shunt into the pulmonary arteries, and you can see the contrast layering out.
Yeah.
It's interesting.
This one's interesting because it's mostly, I mean, a lot of them are usually just on the left side and on the right. And there's a few, there'll be lobular differences. It's interesting. This one gets, the Glenn goes to the right upper lobe as well. But
yeah, but you get coming in right there.
Yeah.
So anyway, I thought that was kind of just neat, something we don't see every day. Yeah, we some of these we try to do MR angio on. First of all, they get a lot of imaging, and so you can get your functional stuff if you're there. But also, we do the multi-phase scanning so that you can get a more homogeneous distribution of contrast.
I have one on my list that's going to take me a good 2.5 hours to get through. I'm very, very excited about that.
All right, let's see here. Okay, who wants to go next?
I can show some.
Okay.
So here's a radiograph with a extra pulmonary bulge at the left apex. And this fellow had had a shoulder abscess a couple months before with some drainage. And here's what things look like at this time. So we have this this pleural collection with some low attenuation and some thicker components and stuff like that. But if we go up higher, we also see that there is a subpectoral component of this low attenuation stuff here too. So we have really a chest wall abscess, and then we have this osteomyelitis of an upper rib here. I think this is the first rib with some erosion of bone. And they have drained this fluid collection here, but they didn't approach this chest wall component. And it turns out that this fellow has a history of lots of bone abscesses floating around his body. Is a diabetic, type 2 diabetic, not very well controlled. But this the shoulder abscess drainage grew Coccidioidomycosis. So this is cocci osteomyelitis, and it does like the upper ribs. We've seen it at the sternoclavicular junctions, and we've seen it in first rib to manubrial junctions and things like that. So this is a good location for cocci. It's a similar location you might see in some cases with tuberculosis. We've also seen vertebral abscesses from cocci. So here's cocci. It had, it doesn't have convincing lung findings for cocci. It does have some lung scarring, but nothing that I could find in any of his imaging going back several years that looked like acute cocci in the lungs. So disseminated cocci here involving chest wall and pleura.
Would not. I've never seen that before.
Now here's a person who had a heart transplant and developed a left pleural effusion and also a lung nodule here floating above the hilum. This nodule was hard to see, and with the deformity from the heart surgeon, stuff like this, sometimes this ended up looking like a vessel or a scar, but actually this nodule appeared a few months ago, and then it was variably recognized and then variably not recognized as well. But eventually there was a CT scan in this case, and you can see that there is a nodular lung lesion floating around here at the apex with a kind of low attenuation center to it, very nondescript. And this thing was fairly indolent. It had been there for, at least I think 3 or 4 months, that time before we got a CT scan that established it pretty well. And serology was positive for Cryptococcus. So this is Cryptococcus, and since it's just serologically diagnosed, it won't be possible to distinguish Cryptoneoformans from gaddii, which is the Northwest favorite crypto species. So we won't know what this is, but the person is getting treatment. So in our differential diagnosis of nodules in a solid organ transplant, such as heart, kidney, lung, liver, so forth, nodules can be nocardia, they can be fungus, it's usually aspergillus, but sometimes it's Cryptococcus, and they can be PTLD. So those are our favorites. So nocardia, fungus, and PTLD are all candidates for nodules. It turns out that we're not very good at distinguishing those possibilities. So this was crypto based on serology.
Oh, so
And then here's a person who presented with some shortness of breath and some chest pain and had this big effusion on the left. And then this is a later radiograph when the, no, I think actually that has gone on to a different case. So I would like to show you some more imaging on this case. Maybe I can find it and resurrect this when I'm offline, okay, because I don't want to take the chance of revealing any patient information. So let me go on to this other case. Here's a person with sort of irregular nodules throughout the lungs, and I can show you a CT scan because I know nobody believes plain films. And let me show you conventional imaging here, not MIPS. And you will see that this person has a variety of lung lesions, sort of bizarre looking lung lesions. Some of them seem to have sort of shelled out and cavitated. This one has got all these little holes in it. Sudhakar, you know, talked about this case, and he showed me pictures of T-cell lymphomas in the setting of HTLV3 infection, I guess, probably in Japanese patients that had similar lesions. Some of these look like little wheels, little pinwheels with holes in them and stuff like this. But this stuff has been going on for a while. We have older CT scans from 2012 where this started to show up as faint ground glassy nodules, mostly in the bases and stuff like this. And this has been biopsied. It's been biopsied again recently. And this is it's called nodular lymphoid hyperplasia. And there is a clone involved in this. I think it's a kappa restricted clone, but there's a lot of other stuff that's not clonal in this, and it's not clearly identified as a malignancy, as a kind of lymphoma. And it's been very indolent. It's been there for 8 years at least. And so, you know, when I see these lymphoplasmacytic infiltrates and things like that, and then the person gets holes in the lung, and this person does have some holes, I start to think about the light chain deposition disease and, you know, metalloproteases being released as the body's trying to scavenge, you know, light chain deposition products and things like that in the lung as a cause of perhaps some of these cavities. So this is being treated as a benign condition. I think it's somewhat steroid responsive. It's been slowly progressing over a long period of time, and it's got this really bizarre appearance. But with most lymphocytic diseases of the lung, there's basal predominance, and this one fits that regard. They did look for IgG4, and there was some IgG4 staining, but it was not considered to be extensive enough to make a diagnosis of IgG4 disease. So there is a component of IgG4, but not that would qualify as IgG4 disease in the lungs. So that question has been asked.
This was all nodular lymphoid hyperplasia, because that's not even a typical look for that diagnosis. I mean, it's just interesting.
Yeah, that's what we got out of the pathology. Okay, now I wouldn't be surprised that if that later turned out to be a you know, a lymphoma, a frank lymphoma. Let me see if I can go back and pick up that other case. Let's see if this, so that was number 4 that I was doing. So it's 2.1. Let me do this. So remember I showed you that big
left peripheral
fluid collection. And this is not the one. Well, we can sort this out. Let's go back.
It was just a one view chest, David. So is it case 3 perchance, or 3 point? No.
So let it must be. I just wonder if I downloaded it. Let me work this out, and I'll get back to you guys.
Okay.
You definitely want to see that case. It's hang on. Here we go. All right, we're back in business. So I may have mislabeled it here. Okay, so I will make this worth your wait. So it turns out that there's this very dense component to that big pleural collection, and this is actually a hemothorax, and there's a big blood clot back there. And it turns out that if we follow the vessels up higher, we get some very interesting blood vessels up high. And I think I can show you a contrasted study. So you can see that these big things are aneurysms and maybe dissections. I mean, there seem to be some little septa floating around in there. So we've got this really huge one of this right brachiocephalic, and we've got a pretty good sized one over here too. So we've got these aneurysms there. We go down into the abdomen, we find that there is an aneurysm of a mesenteric artery here, I guess. So we've got this aneurysm down here. We've got aneurysms all over the place. There's a nice gallstone there. And this person has a diagnosis of Ehlers-Danlos type 4. So they didn't identify the bleeding site here of this. They are very hesitant to operate on this person. They didn't want to place drains and things like that because everything is so fragile that they can actually make the situation worse by operating this person. I think this person might have eventually had a VATS, so that gave them good control, and they evacuated a hematoma, I think, on this case. Other than that, they haven't treated these aneurysms because treatment evidently makes them worse and causes them to bleed. The tissue's so fragile that to operate on it actually makes things worse, not better. So there's some very nice 3D reconstructions that I have to anonymize before I can show them to you, but I'll include those on the postings. So here was hemothorax caused by Ehlers-Danlos, bleeding vessel not really identified in this particular case, but very nice aneurysms of brachiocephalics. I don't think I've ever seen a case like this before.
So,
but Seth, you probably have 40 of these, right?
David, I showed a very similar case maybe back in December. It was a iliac artery aneurysm that was picked up. So it was a vascular study, and it had the same kind of thing, not to the same degree, but had funny. And at that point they hadn't gotten genetic testing yet, last time I checked they hadn't done it. But I wonder if it was the same thing, because that's what I'd suggested was that vascular variant of Ehlers-Danlos, because there's not a lot else you think about.
Right. So this guy had the classic genetic mutation that goes with type 4. So
yeah, I don't think I've seen central venous dilation that pronounced. I've seen varices of pulmonary veins and stuff, but
this is arterial, Seth. These are brachiocephalic arteries.
Oh, I'm sorry, I wasn't even. Oh, that's pretty big. That's impressive. Sorry,
well,
I just saw the image. I wasn't sure if they're veins or.
That warms my heart, Seth. I impressed you. So
yeah, no,
okay. Well, I think I'll quit there. It won't get any better than this.
All right.
David, if you scroll down back to that fluid collection, did anyone see displacement of fat such that extrapleural fat, such that it may be an extrapleural rather than an intrapleural? Doesn't really matter too much.
I think that's a nice idea.
I think Superior is trying to decide whether I saw a little bit of extrapleural fat displaced, like right there, right in the top of it, the very apex of it, and even a bit higher.
Yeah.
I'm not right. Is there a slip of fat there? I wonder about that. Oh, look, there's a little crescent of fat almost.
There.
Or it could be both. Could be both.
That's interesting. That's a good pickup. That's an interesting pickup. Yeah.
Yeah.
So maybe it's bleeding from.
That's
an
probably
extra-
a lot more. That's probably a lot more painful, right?
You'd
Or
think that's a good point. Yeah, the pleura must be very irritated. And so back here, it looks to me as if the hematoma goes right up to the bone too. But there's no fat stripes separating pleura from bone the way there normally would. So I think you're right. This may well be predominantly extrapleural. It also is very confined back there, doesn't it? And sort of convex top to it would be good for something being.
And especially up here, it looks like there's a pleural fluid collection, and then the actual.
Right.
Yeah.
With people,
fat separating it.
It's a very good pickup. Yeah.
Good observation.
Wow.
All right. Seth or Howard?
I have cases.
All right.
Let's see here. So I will do my best to make this exciting. Let's see here. This is a patient who presented outside hospital with this, came in, younger patient, I can't remember her age, 30s or 40s, cough and hemoptysis, came in with this lesion, was being worked up for malignancy. And you can see that there is this ground glass, predominantly ground glass, some soft tissue, which is interesting, soft tissue extending around, especially the pulmonary veins. Pulmonary veins, not really conspicuous, maybe minimally narrowed, but that's on, that's on the 15th. This is then the 19th. Starting to see a little bit more abnormality around it. Patient had, at this point, I think, frank hemoptysis, and this was some presumably pulmonary hemorrhage she underwent. And then you can also see that there is now more conspicuous narrowing of the pulmonary veins, and also some soft tissue around the pulmonary venous structures. You can see abnormal ring of soft tissue here. And then this is now, shoot, I keep doing that. 3 days after that. And here is, now she has areas of cavitation within this, areas of hemorrhage cavitation are nice, interestingly, clearing around the bronchovascular interstitium in this younger patient. And then more conspicuous abnormal soft tissue in the left hilum. And again, really obliterating now this pulmonary vein. And this patient initially they weren't sure if it was aspergillus or mucor. She wasn't immunocompromised, I don't believe. Then they actually took this out, and it was mucor, and there was extensive invasion around the pulmonary venous structures and into the pulmonary veins. So she went for a completion pneumonectomy. And during this time, she also had, unfortunately, more disseminated mucor as well. So now it's in her brain. So unfortunate patient with disseminated, a young patient with disseminated mucormycosis infection.
Diabetic?
She is diabetic. Yeah. So, yeah, she is absolutely diabetic. But otherwise relatively healthy, except for the diabetes. But you're right, she is diabetic. This is,
I guess the organisms could easily have gotten into the pulmonary veins and then just a huge load of them just going up the arterial system to the brain.
yeah.
Presumably that's awful. If that's the mechanism.
No, that's exactly what. And I think she had some abdominal stuff as well. They commented on, but the chest and the brain was.
Oh, it's bad luck.
Yeah. And then where is my other? Shoot. Well, I'll show this one. I have there's an old one too. I can't seem to find it here. But this is I'm curious, what do you guys do for your CTAs? Someone comes in post-operative, what's your protocol? Do you do a non-con on people? Do you do an arterial? Do you do a delayed? I find that everyone does it differently. And I'm curious what you guys tend to do on your arterial or on your your CTA studies?
We tend to do three non-contrast, immediate, and slightly delayed, particularly if it's a complicated one. But yeah, we typically do that nowadays.
We've started doing that, and it's helpful. I've always kind of shunned the non-contrast for the most part because it's just extra radiation, but it is definitely, I mean, it's all helpful. It's just how much radiation you want to give.
Yeah.
This one, it's definitely what's more helpful is the delayed. And if I had the first, this one you can see it as well. So this is too early. So I guess they acquired it too early during more the pulmonary arterial phase. And what you can see is this large pseudoaneurysm. There's leakage from, they tried to fix it, but there was just a clear leakage between, this patient had a type A dissection between the false lumen up in the arch. There was leakage here into the ascending aorta. And this had been going on for many years, and they were watching it and watching it grow. You can also very nicely see the compression and the decreased flow to the right. But on the delayed phase, it was subtle and nicely picked up by one of our junior faculty. He noticed that on the delayed phase, there was actually this kind of, looks like a little blush here from the back into the PA, and more intense enhancement of the right PA than the left PA. And this was taken to surgery and confirmed to be a pseudoaneurysm to a pseudoaneurysm. So a connection between the false lumen from a leak into the PA and that decompressed into the pulmonary artery. Seen that a couple times, but not very common. So here you can see it's amazing, like the false lumen just flat out just connects with this large aneurysm, pseudoaneurysm, I don't know what you want to call it, but then decompressed into the PA. And then this case, I know there's a lot of images here, a lot of studies. This is cool because it's just, never understood clear all this. Oops, sorry. I never understood how broncholiths develop, the whole concept of, I mean, I understand people say that, oh, you have lymph nodes and the lymph nodes erode into a bronchus. I never really, I mean, I understand the concept. I just never really thought it was true. Just seemed like an odd mechanism. But here's this patient, and I have more images where you can actually see this exuberant calcification from these calcified lymph nodes and actually kind of poking into and extending into the bronchus intermedius here. And then over time, this thing got more and more into the airway and started kind of going, looks like indenting on, but eventually presented with complete collapse of the right upper lobe and right middle lobe. And then this thing had actually worked its way into and occluded. And when they went in on bronchoscopy, they said there was an actual, it wasn't just pushing on the, from externally and pushing up and narrowing, it was actually a big chunk of broncholith within the airway itself. So it's a really, I just had never seen that progression before. I mean, I've seen broncholiths and I just never really thought that it could over time really erode into the bronchus, but here's a case kind of showing that over many years doing that. So I thought that was pretty cool.
People cough those things out and they're described as looking like unpopped popcorn kernels.
Oh, really?
Yeah.
And then lastly, I don't remember. Oh, this is just a acute case that just came in the other day. Or we just was showed to me the other day. It's nothing, it's just a young kid with ugly looking bronchial mass, pretty early arterial phase, but pretty avidly enhancing. Looks kind of a little bit ugly down here as well, but they were able to do a sleeve lobectomy, and this was a carcinoid. I was worrying if it would be an atypical carcinoid or something a little more aggressive, but it wasn't. It was just a simple carcinoid. He had a congenital syndrome as well, I think. I can't remember what he had. I don't know if it was associated with carcinoids or not, but do you remember what syndrome he had? Anyways, just a carcinoid in the right upper lobe bronchus. But those are my cases.
All right. All right, Howard, you ready?
Okay. This is the case that I started to show you folks last week after the end of our conference. So I'll show you it again so that folks watching the video can see it as well, and a bit of follow-up. So the history is familial pulmonary hypertension. It turns out to be the BMPR, bone morphogenetic protein 2 associated mutation. So there's a strong family history, and he's had this for a long time. So he had a history of a previous episode of pulmonary hemorrhage, and we see one embolization quelling one location in the right upper lobe. And this presentation was additional hemorrhage in the left upper lobe, as you can see there. Now, on the report of the outside CT, they described the unusual vessels, but they used the term multiple AVMs. And no, it's not multiple AVMs. This is just a dramatic case of the so-called neovascularity of pulmonary hypertension. So we have the very tortuous corkscrew-like pulmonary vessels, the small ones, as well as these multiple areas of ground glass attenuation in the lungs, in the areas in which you see those vessels. So if you do a MIPS, it was pretty dramatic. It looked like that. And here you can really see the very tortuous, elongated corkscrew pulmonary arteries, and then the ground glass attenuating opacities on this enhanced scan about them. And the other thing that we see here is the very enlarged bronchial arteries. So they embolized a bunch of pulmonary artery branches in the left upper lobe. That was done on 2 occasions, but the bleeding didn't stop. And I was pretty certain these are not AVMs. And then, of course, one would potentially ascribe the hemorrhage, which was unrelenting, to these hypertrophied bronchial arteries being so big and potentially communicating with pulmonary arteries. But they did then, after that, do some bronchial arteriography, and I'll just show you a couple of images of how massively dilated and abnormal the bronchial arteries are, which they subsequently embolized. So we see very, very big pulmonary arteries. So after embolizing all the bronchial arteries, the hemorrhage stopped. He's still pretty sick, having undergone all those procedures. And this is the image that I showed of at least the left upper lobe pulmonary arteries and how they look the way they do. So the concept of neovascularity really comes from initially this article. Actually, it's not that one, but this is an additional article that I have, in which they look for lung neovascularity associated with congenital heart defects. That was the first article, as well as idiopathic pulmonary hypertension. And then just to show you a couple of images from that, you can see the neovessels, the tortuous vessels, and then you can see images that look like this as well. So we had bronchial arteriography, the hemorrhage stopped, but he's still pretty sick overall, because he had right ventricular failure and a bunch of other complications that happened. So that's some follow-up in that patient.
Howard, one of the findings in this is, and it's shown in this illustration as well as your case, is that in the center of the ground glass, tuft, you'll often see a dilated, sort of a microaneurysm of the pulmonary artery in the center of that lobule. And you showed that when you showed the arteriogram, you could also see tiny little aneurysms associated with that left upper lobe injection. You see the little dots there, just above like about 2 inches, an inch from the tip of the catheter, just above. See the little dot. So, so if you move your mouse, right there. So, right in there. So see there, and they're farther up, way up at the top too. There's the tiny little aneurysm of that tortuous vessel. So that's one of the findings you see on CT. You'll see that the artery sort of becomes dilated right in the center of that ground glassy tuft. As you scroll through, there's this little aneurysm component. I think your case shows that within the ground glass, there's a little aneurysm of the pulmonary artery.
Hard to say, yeah. So that's a pretty dramatic case of neovascularity, not AVMs. So he underwent some procedures that were really not indicated, which really it didn't help him at all. Okay, I'll show you this one, which is almost an everyday typical traumatic neural injury to the aorta. So what's a little bit unusual about this one, and we've seen this before, first off, their location of this is a little bit more proximal in the aortic arch. So usually we see traumatic injuries about here. And this one, we begin to see this, and we begin to see that a little bit more proximal than usual. And then I'll bring up just a couple of images to show you that otherwise it's pretty consistent with a type 3 injury involving that portion of the aortic arch. And then what's interesting about this is the amount of intramural hematoma in the wall of the aorta. And it actually, as we go up, you can see it goes up fairly circumferentially around the left subclavian artery. So it goes up there for a short distance like that. But the blood's certainly in there and it's dissecting along that subclavian artery. And there's some undoubtedly blood in the wall of the aorta here. So some features that we don't see that often, but that we may see. And it's got a lot of fractures, a lot of extrapleural hematoma, many rib fractures and other things. This is sphere versus tree, a bad one. Okay, Jeff, those are mine.
All right. Well, thanks, everybody.
Thank you.
Good stuff. Talk to you next week.
Thanks, everyone.